Welcome to this explainer. Today, we're going to put on our detective hats. Because let's be real for a second, medical coding, it is definitely not just data entry. It is high-stakes detective work. And it's a field where things are constantly miscategorized, which literally leads to millions of dollars in denied claims and skewed patient data every single year, right? You're tasked with decoding these really complex, often chaotic, real-world events into a precise, accurate medical record. So today, we're tackling a particularly tricky mystery, distinguishing between recreational substance use and clinical poisoning. Okay, let's dive into this by confronting a major assumption right out of the gate. Is an overdose always just recreational drug use? In the fast-paced environment of healthcare, it is incredibly easy to see a chart detailing an overdose and immediately assume, oh, it's simply a case of recreational use gone wrong. But as medical detectives, we know that assumptions are the enemy of accuracy. The reality is far more nuanced, and getting this distinction wrong, well, it alters the entire clinical narrative of the patient. So let's look at part 1, recreational use versus poisoning, and their diverging paths. As you can see here, there's a stark visual divide between these two. On one hand, we have recreational drug use. Here, the consumption is entirely voluntary. The patient is making an active choice, and their specific goal is to achieve some sort of mind-altering effect. Think of someone actively choosing to take an unprescribed stimulant for a quick high. Now contrast that with poisoning on the other side. This is an involuntary, harmful exposure to a toxic substance. This is the toddler accidentally swallowing a household cleaner under the kitchen sink. The fundamental difference between these two clinical scenarios really just hinges entirely on volition and intent. Did the patient mean to take it, and did they mean for it to do what it did? So the crucial point is this massive caveat. An overdose during recreational use is a form of poisoning, but not all poisonings are recreational. For example, a patient might voluntarily take ecstasy at a music festival, seeking a high, right? But then they involuntarily cross that physical threshold into a toxic, life-threatening overdose. The lines of intent and consequence blur dangerously here. It's a really complex situation where the two definitions overlap. And that is exactly what makes your job of pulling them apart and documenting the exact reality absolutely vital. All right, moving on to part 2, decoding the ICD-10 system, specifically F codes versus T codes. In our medical coding toolkit, we have specific alphanumeric categories to capture exactly what happened. First up are the F codes. ICD-10-CM F codes indicate that there is a true diagnosed drug issue at play. You can basically think of an F code as the official clinical stamp confirming a pattern of substance abuse or dependence. When you use an F code, the documentation clearly states that the patient isn't just interacting with a substance randomly. No, they have a recognized underlying condition driving that voluntary use. Think of your F11 codes for opioid dependence, for example. Let's move to and see how this builds by layering in the T codes. So, unlike the behavioral patterns captured by F codes, T codes define the actual physical event of the poisoning itself. These are the ICD-10-CM codes you use to explicitly report an overdose, an adverse effect, an underdose, or just a straightforward clinical poisoning. They describe the acute harmful exposure, like a T40 code for an acute heroin overdose in that specific moment in time. But how do you know which to use, or if you even need both? Well, documentation is key to proving the link. You absolutely need rock-solid documentation to understand if a patient was using a substance recreationally, which then directly led to a clinical poisoning. Without that precise, detailed narrative from the healthcare provider, a coder is literally just guessing in the dark. You simply cannot connect the F code behavior to the T code event unless the medical record explicitly hands you the magnifying glass to see that connection. That brings us to our final actionable phase. Part 3, the keys to documentation and finding the clues. Now, what's really interesting about this slide is that it gives you a perfect 5-point clinical checklist. These are the fundamental pillars that help you correctly differentiate and document the event. First up is intent. Was the goal a mind-altering effect, or was it entirely accidental? Second is dose. Exactly how much was taken? Third, the substance. What specific toxic agent is involved here? Fourth is context. What were the surrounding circumstances of the exposure? And finally, consequences. What was the physical fallout? By asking these specific questions as a reference, you extract the exact data needed to confidently assign the right F codes and T codes based on the provider's documentation. Which leaves us with this final critical question. When a patient's story is complex, does your documentation tell the absolute truth? It is so easy to view medical coding as just administrative red tape or a tedious data entry chore, but I really challenge you to see it differently. Your coding is the definitive, truthful record of a patient's medical reality. The distinction between a voluntary recreational choice and an involuntary toxic poisoning completely changes how that patient's health history is understood and treated in the future. So the next time you're faced with an overdose case, are you going to just skim the surface, or will you dig deep enough to uncover the real story?